honorable chairpersons and learned audience, very good afternoon. Today my presentation is a story of ignorance, mistakes, and failure. When I thought of presenting this case, there was intense repulsion from inside, but I could convince myself saying that even a single doctor, if learned from my mistakes and save a patient, this will be a great achievement for me. So my first case is a 49-year-old male who presented with exertional chest pain for last 2 months on the background of hypertension and smoking. And ECG showed anterior ischemia, and there was anterior and septal wall hypokinesia with ejection fraction of 45%. So the coronary angiogram shows there is about 70 to 80% stenosis in the proximal and mid part of the LAD, followed by 100% stenosis in the mid part. So this is the view of RCA, where you can see there's only mild irregularities in RCA with retrograde to the LAD. In the second view, there is a white line in the mid part with sluggish flow, and the flow further sluggish in the next view. So what is this white line? While we were arguing this, and I was saying this may be a dissection flap, all my colleagues were saying the catheter tip didn't went up to the mid part. How can this be a dissection flap? So for a clear understanding, I made this 3D video. So the catheter-induced dissection occur where, and the dissection flap went from posterior to anteriorly like this. So this twisted part is viewed in the coronary angiogram like a white line, and the blood and dye accumulated in the false lumen, which is seen in the coronary angiogram as a holding of dye. So my recommendation for this case is you have to promptly identify and take action in case of dissection occur, or you lose the patient. Because in this case, we have lost the patient because RCA is the only feeding artery and we could not manage the patient. My next case is a 52-year-old female who presented with recurrent chest pain for last 2 months on the background of hypertension, and ETT was positive in the second stage. The coronary angiogram of the left side was normal. In the right side, there is a black wave of dye moved from the proximal to distal part. I have never seen anything like this before. The patient suddenly developed chest pain and became hemodynamically unstable, and patient developed complete heart block. This time we were very prompt. We put a temporary pacemaker and weighed down the vessel. We thought this could be a spiral dissection with intramural hematoma, so we promptly put a 3 × 38 millimeter stent in the proximal part in order to seal the proximal entry of the dissection. So, but when we took view, there was no flow in the mid and distal part, so we negotiate another wear, and after wearing, there was some antegrade flow. So we thought that we have missed the proximal entry of the dissection, so we put another 3.5 18 millimeter stent in the proximal part and the third stent in the distal part overlapping with the first stent. And after that, we can see the dissection propagated in PLB and PDA. So we did POBA in PLB and PDA and tried to stent the PDA but failed. So this is the final picture. So my recommendation for managing these patients are prevention is better than cure. So do not inject when there is dampened pressure, and catheter should be always kept coaxial. Even then, if arterogenic coronary dissection occurred, there should be no further antegrade injection. Patient should be hemodynamically support should be established. In case of minor dissection, no treatment may be needed, but if the dissection causes more than 50% stenosis with impaired TME flow in a vessel of more than 2.5 millimeter, it should be considered severe. We should try to wear down the true lumen. If we are successful, we should stent the vessel distal to proximally, and we can take the IVUS to confirm that whether we are in the true lumen or not. If we fail to get the true lumen, we should try IVUS guided rewiring. If we fail, we can try this parallel wear plus straw technique, which is an interesting technique. If I get time in the question answer session, I can show it to you. And there are other bailout strategies such as retrograde approach, re-entry with stingray, wire-based catheter entry. If we fail, we can send the patient for cabbage and conservatively manage the patient. So stenting of dissected vessel is different from stenting of non-dissected segment because of higher rate of complication, because of propagation of intramural hematoma in the distal segment causing extension of dissection, and later stent malposition due to hematoma resorption. So for stenting of dissected segment, we should be less aggressive. There should be no pre and post dilatation, and we should not oversize the stent, otherwise it will push out the hematoma. And longer stent should take, so both the proximal and distal end of the dissection should be pinned off. So my take-home message is learn from my mistake. And here in my cases, I put stent in the proximal segment first, so there is the hematoma move in the distal segment. So we have to seal both the proximal and distal segment. If it is not possible, first we have to stent at the distal segment and then the proximal segment to seal both the end of the dissection. So I finish my presentation with this quote. Thank you all for patience hearing.
Thank you for your brilliant presentation.